Hello and welcome, and thank you for joining us for what we hope will be an interesting and informative discussion and around some of the latest data in rheumatology. My name is Professor Peter Nash from beautiful downtown Brisbane, Griffith University, and today I'm delighted to be joined by Clinical Professor of Medicine, Professor Roy Fleishmann from the University of Texas Southwestern Medical Center in the USA. Hi Roy, thanks for giving up your time. We appreciate it greatly. We're going to be talking about his study recently published in J Rheumatology, radiographic progression of structural joint damage over 5 years of baricitinib treatment in patients with rheumatoid arthritis. Let's get a bit of background, Roy. How's COVID affected your practice? How COVID's affected the use of JAKs and the vaccination story with JAKs in your part of the world?
That's a complicated question. You have three answers in there. So COVID has affected us as it has affected everyone else. Currently, we're in a downturn. We have very little relative infection rate. So we're doing pretty well. We seem to have gotten over the Delta surge. Of course, the practice was impacted significantly during the depth of the pandemic, with patients not willing to come in or unable to come in. But that has reversed and we're pretty much back to normal. Everyone's been vaccinated, or at least they tell me they've been vaccinated. I don't know about all the patients, probably not. As a matter of fact, I know not. There are certain segments of the population in Texas that are reluctant, which is ultra conservatives, as you know. Now we have some minorities that are reluctant to be vaccinated for reasons that they think are reasonable. And we also have patients who had COVID who really don't want to get the vaccination, although I tell them that they'll be super secure if they did get the vaccination. How has it affected us with respect to JAKs? It actually hasn't. So the reason why I say that is, as I'm sure you know, there was a presentation at EULAR and a publication, I think it was an A&R, that the patients who are on different biologics or target synthetics, and how do they do with COVID? And that publication strongly stated that rituximab is not a good drug to be on if you're going to be vaccinated. And it also suggests that JAKs are of difficulty. That was interesting. There was a letter to the editor from Ron van Vollenhoven, who I know you know, Netherlands, who asked a very interesting question. The study was done and looked at patients who required oxygenation or hospitalization or ventilation. What was their medication on when they got, what were they on when they got sick? And that suggested that the odds ratio of having a worse outcome with JAKs was actually 2. It was worse. The question he asked was, what about patients who continued the JAKs versus those who discontinued the JAKs? I don't know if you saw that letter to the editor in the reply. Reply was very interesting because the reply actually went into that and said, well, we were able to subset the population. I can't remember the exact numbers, but if there were 300 patients who were in JAK, 200 stopped and 100 continued. And the 200 who stopped, they did have more difficulty with hospitalization, oxygenation, ventilation, and mortality, as a matter of fact. Those who continued had almost nothing. And you would think that that's correct because the JAKs actually should be somewhat protective from COVID. So in speaking to patients, I tell them, well, the American College of Rheumatology, the Global Alliance Rheumatology strongly suggests you stop the JAK. But you have to be out of your mind if you do that, because here's the data. And the data is, if you're doing well, continue the JAK.
And the barry is now being used as a treatment for COVID. So.
And barry is being treated for COVID. There's also some information about tofacitinib, that tofacitinib is actually helpful as well. I haven't seen any with upadacitinib, but I would assume that it would be similar.
Now, the big gorilla in the room, has oral surveillance affected American rheumatologists' practice, prescribing habits, or are they waiting to see the peer-reviewed paper?
Okay, the peer-reviewed paper has been submitted. The revision has been done. The revision has been submitted, and I'm pretty sure that it'll be accepted. This iteration of it will be accepted shortly. So it should appear shortly, I would think. There are 4 or 5 presentations at ACR on oral surveillance.
Yep.
And I am actually giving the main primary talk, which of course EULAR rejected and which ACR accepted as a poster. All the sub-analysis are orals. If you can explain that one to me, then you're better than everyone of us I've spoken to. Oral surveillance is a very interesting study, and in our group, we have a very large group. We have 20 rheumatologists. There is mixed opinion. If you really look at the data from oral surveillance, this is a very, very specific population. It's an older population with cardiovascular risk. The EMA has already come out with their suggestions, which are reasonable. There were not statistical differences, incidentally, in terms of MACE or malignancy or VTEs in oral surveillance for tofacitinib versus the TNF inhibitors. But the primary outcome of the study was a little unusual, not unusual for the FDA. It was the upper limit of the confidence interval of combined TNF versus TNF, combined TOFA versus TNF. And the upper limit of the confidence interval was higher than 1.8, which was the preset determination. But you'll see all the data, and actually the confidence intervals overlap. So there is a numerical difference with TNF, which favors TNF over tofacitinib. I think that's very clear. But one of the things that we talk about in the presentation, the number needed to harm, one of your favorite little thoughts, as a matter of fact. And the number needed to harm for MACE is over 550. So you have to treat 550 more patients per year with tofacitinib to have one more event than you would have with a TNF. And for malignancy, it's about 270, if I remember correctly. It's around there. So those are large numbers, right? So the point that the EMA said was, well, if you're over 65 and you have any history of smoking, that's the group that's at risk. And in that group, speak to the patient. Maybe you should use a JAK after you use other agents. And I don't think that that's unreasonable. Maybe you start patients on methotrexate, and after methotrexate, you go to targeted synthetic or biologic. A lot of the patients like the targeted synthetics because quickly. But the truth of the matter is if you take a look at one versus the other, they're both good, right? In oral strategy, TOFA was similar to starting adalimumab. And with upadacitinib, select compare, as you know, upadacitinib was superior. And in RAB, with baricitinib was superior, but a little bit superior. So why not go to a TNF in a patient who's older, has a history of smoking or other risk factors? But under the age of 65, if the patient hasn't smoked, see the incident rates in all these orals on MACE, malignancy, VTE, the risk is really, really low. Yeah. So it hasn't changed my practice, but it has changed some because some interpret this study is showing that there is an increased risk of malignancy in MACE. I don't think that's true. I think that TNFs reduce the risk, and TNFs don't reduce it quite as much.
Yes, and those that don't read the fine print see the FDA slap against a class, all JAKs, and then all inflammatory diseases, no matter if the risk is very low with AS compared to RA. So I think that's the perception, that they're, without reading the fine details, they've slapped it on the class and they've slapped it on every indication, which makes it very tricky to use.
Yeah, but I want to make a comment about that. So I've looked at the integrated safety analysis of baricitinib, tofacitinib, upadacitinib, and filgotinib. And it turns out that in their integrated safety database, and if you look at MACE malignancies, the rates are almost identical with all four drugs. And I'm not sure, I actually think the FDA is correct. I think it should be a class effect. The fact that there isn't a study with baricitinib, there isn't a study with upadacitinib, there isn't a study with filgotinib, doesn't mean that if you didn't do the study, you wouldn't get the same result. So if you're looking at safety, which is what the FDA looks at, right, it's not unreasonable. You can make an argument either way. But going to other diseases is unreasonable. The patients, certainly with inflammatory bowel disease, are much different than the patients with rheumatoid arthritis. The patients with ankylosing spondylitis are so much different. Their comorbidities are different. Their risk factors are different. PSA, in some ways is closer to RA, but again, it's not RA.
No.
Right? So why you would go to all those diseases, and the EMA didn't do that. EMA was specific for tofacitinib, specific for RA.
Yeah, excellent. And I think it'll be interesting in the UPA Select program, one arm is adalimumab in the same patient population, same disease duration, etc. And they've extended that arm for quite a length of time. So it's almost like they've done that mini study for us, and we look forward to those results. So let's talk about this paper.
But I just want to make one comment. The Select Compare, which is what you're talking about, which is a 10-year study, and you're correct. It really goes for a long time, which is what we're going to talk about baricitinib in a moment. The fact of the matter is that there were very few patients compared to Strategy. Strategy had 5,000 patients. This is,
much smaller.
So you really can't make the determination.
Okay, so we're talking about an X-ray paper. Rheumatologists always like to know that a drug inhibits progression so it's not an expensive NSAID. Do you do many X-rays anymore, Roy? We're finding that with ultrasound in our clinic and a bit of MR, we're hardly doing X-rays unless there's a reason.
So when the first patient first presents, and I have the diagnosis of RA, I do an X-ray.
It'll be normal then, Roy.
What?
It'll be normal at presentation, pretty much.
Well, it depends upon when the patient comes in. I'm saying at my first visit. So the patient, if the patient has a month of disease or 3 months of disease, maybe not, right? It usually is negative. But if they have, a year of disease, year or 2 years of disease, which is not uncommon, you can find erosions. But that's the only time I do the X-ray. That's the only time I do the X-ray. Doing ultrasound or doing MRIs, I don't do many of those either. And the reason being that all the drugs that we use inhibit radiographic progression. So if I use a drug, we're going to talk about baricitinib in a moment, and if I start the patient methotrexate, they don't respond in 4 months the way that we want to, and I add baricitinib 4 milligrams, not 2 milligrams as in the US, but 4 milligrams as you can in Australia, plus methotrexate, I know I'm going to limit radiographic progression in 95%, 98% of patients. And if the patient does very, very well clinically, but they still have progression, which I could find about an ultrasound or MRI, what am I going to do? And how do I know the drug I'm going to switch him to is going to be as clinically as effective? Because now the patient's functioning, sleeping, and doesn't have fatigue, and can work. How do I know the drug that I'm going to switch into is going to work as well and it's not going to inhibit radiographic progression. So I actually don't do much imaging anymore.
Right. Well, I agree with you. We only do ultrasound in the seronegatives we see very early, very inflammatory story, but nothing defined. And we're just looking for some subclinical synovitis. And the only other one I ever do it in is someone in remission who we want to taper. If there's some subclinical synovitis, the taper and cessation will be unsuccessful. But if they've got nothing there, then your taper is much more likely to be successful. So like you, we're doing it less and less and less over time.
Yeah,
so
but
let's
I think
talk about
those two instances are reasonable.
Yeah.
I would agree.
So let's talk a little bit about this paper. It's the RA Beyond study. Can you tell us how that was put together, please?
So in the baricitinib clinical trial program, the phase 3 program, there were 4 studies, right? And several of those studies, 3 of those studies looked at radiographic progression. And they looked at radiographic progression as all the drugs do, over 3 months, over 6 months, over a year. That's how long the studies go. But in RA Beyond, which was a long-term extension, right? So the patients who did well, could tolerate the drug, were maintained in the study. And those were the studies that fed into, the phase 3 studies fed into RA Beyond. So it was RA Begin, the patients who were methotrexate naive, the patients who were TNF failures, the patients who were conventional synthetic DMARD failures. And what we were interested in, and interesting enough, we haven't seen another report of this. What happens long-term with radiographic progression with patients on a drug? We know that initially, they all work. They don't work in everybody, but they work in the vast majority. But is that radiographic progression still inhibited 5 years later? So we had an initial paper that was the 2-year paper, which suggested that it did. But 2 years in a chronic disease isn't very long. So we now have the 5-year paper, which is lengthy. And it's the only one that I've seen which has looked at radiographic progression in a number of patients.
Did you have good retention through the 5 years, or was the patients not doing well who may have progressed dropped out?
That's true, they did. Right, the patients who didn't do well on the drug dropped out. Patients had side effects, dropped out. If I remember correctly, it was about a third of patients who did that. So as we all know in clinical practice, if you start a drug, any drug in a patient with new disease, probably 80% respond right away. But how many maintain that response? It probably is 60%, 65% over a prolonged period of time. That's kind of what we saw in RA Beyond. There were differences in the studies because we had early RA, and we had late RA, we had TNF failures, and there was a difference between those two, obviously.
Okay. And can you tell us a little bit about how you analyzed the X-rays and the sort of methodology of what you did so that we can talk about the results?
Yeah, so the radiologist looked at the X-rays, right? So I did look at the X-rays for my own patients, but the radiologist really did that. So they had several campaigns. So there was a campaign at the end of the first year, or 6 months of the study, or 1 year of the study, depending upon the study. That was one campaign. And then they had a second campaign after 2 years, right? We were looking at what had happened over the 2 years. And they had a third campaign, which is what this was, reanalyzing the data over 3 years. I can tell you that about 3/4 of the patients, we had X-rays all the way through.
Okay, right? So that's very high.
Right.
Yeah.
There was no imputation of data. The patients where we didn't have all the X-rays, it was about 25%. We used linear extrapolation from the last one.
Yeah, I was going to ask you, should we know anything about the stats, or was it pretty straightforward? Because you taught me that you shouldn't analyze studies where you have early disease, late disease, TNF failure, TNF naive, all mixed in together.
So what we did was we actually separated that in the paper. So we talked about the early disease, we talked about the conventional synthetic DMARD failures, and we talked about the TNF failures. And we showed tables for each of those three. The results were fairly similar.
And tell us those key results so that the clinician can have a takeaway message.
Baricitinib works.
And it worked better if you were naive than if you were a failure.
Yeah, so the answer to the question is, so baricitinib did work. It worked in all three patient populations, and there was significant inhibition of progression. But clearly, it works better in the patients who are naive. And what we also found was in these studies, there were switches, right? Patients were put on placebo, plus methotrexate, let's say, and then if they didn't have a response, they would switch to baricitinib, or after a period of time, they rolled over the LTE, they were put on baricitinib. The patients who started baricitinib, right, all did better than the patients who were switched later on. And of course, you know, anyone, what would you expect? And that's what you would expect, because radiographic progression doesn't go away, right? If you have progression, you don't get back to normal. So if you have 6 months of progression, it's going to be there. But baricitinib does work well. We had an adalimumab arm in one of the studies in our beam, and that worked well as well. So the earlier you start the biologic or the target synthetic, in this case, it's mostly target synthetic, the more likely it is that you won't have radiographic progression.
And you did measure some SDIs of efficacy. Were you able to show that disconnect that was shown with the TNFs, where you can stop progression even in those people who you can't adequately control their inflammation?
Right. So that wasn't the aim of this study, right?
Right.
Because this is a long-term extension. So the patients in the study all really responded well. If I remember correctly, 80%, maybe a little bit higher, they were in SDI low disease activity. So we really didn't look at that. What you're talking about with the disconnect, to me, has always been a little strange. I remember Peter Lipsky actually presenting that for the first time with infliximab, and showing that infliximab will inhibit radiographic progression even when the patient doesn't respond. To which my reaction was, what do I care? I'm not going to continue the infliximab, right? But my guess is that baricitinib will actually do the same. But why would you continue the drug if the patient is not doing well?
Doing well, fair enough. And was there a dose effect? Does the two actually contribute to preventing progression?
Yeah, so that's a really good question. We couldn't answer it. And the reason why we couldn't answer it was because in Beyond, there was a group that if they achieved a remission in RA beginning, the methotrexate population, or if they achieved LDA, and this was CDI, LDA, CDI remission, in the patients who are on conventional synthetics, then there was a group that was moved down from 4 milligrams to 2 milligrams. And if they didn't respond, it could go back up to 4 milligrams. But if they responded again, you could go down again. So it was very, very difficult, actually impossible. We asked the statisticians, I don't know how many times, to try and tell us whether there was a difference between 2 and 4. But we really don't know. We do know that the 2 works, but we don't know how well it works versus the 4.
Excellent. And the only other thing might be monotherapy. Was there enough not on methotrexate to comment on radiological progression, mono versus combo?
Yes. And mono still works.
Still
not
works.
quite as well, not quite as well as combo.
Yeah, that's the question.
Right.
So you're better on combo always, unless you just can't tolerate MTX and there's still efficacy with mono. Because the mono population here is about 25-30%.
Yeah, but the progression on mono is not quite as good as, it isn't quite as inhibited as combination, but it is inhibited, right? So when you when you're speaking to the patient, right, and you're getting the patient input into this, how are you doing? You know, I can't stand the methotrexate, or I have headaches with the methotrexate, noise with the methotrexate. But on the mono, I am functioning well, right? And radiographic progression is inhibited to a fair extent. You know, that's really reasonable.
Yeah. Okay.
But I always try and keep combination. I do try and keep combination. But the truth of the matter is, when they practice, probably 2/3 of patient are a mono. Well, once they get into remission or persistent low disease activity.
And that's kind of an issue, talking about this perception from surveillance. The mono market here, you can't get Actemra, tocilizumab for love or money. It's all gone in the COVID treatment. So there's none available for our patients. And we've had to switch everybody off, the GCA patients, the RA patients. We don't have a second 6 inhibitor. So the JAKs are the mono market. And until people actually look at the fine print of surveillance, that mono group is struggling at the moment. So any other
why is that?
Because they got this perception. They got this perception the JAKs are now dangerous as a class for every disease. So there's a lot of educating that needs to happen.
Yeah, so I want to make one comment about that. So you talked about the FDA. The FDA went all diseases, and they said it's all diseases and only after TNF. So I think that's draconian. That's a strong word, but I'm going to use that word. And the reason why it's draconian is for the patient that you just talked about. So if a patient you put on methotrexate, a conventional synthetic, they don't do well, and they can't tolerate methotrexate. So you have to take them off methotrexate. And if you take them off methotrexate and you go to a TNF, the TNFs don't work that well as monotherapy. Right? No matter what other people say, they don't work as well. So what would you go to? Well, you go to an IL-6, right? Because an IL-6 works better, but you can't get an IL-6, right? So, but let's assume you could get an IL-6. So you do 3 months of methotrexate, and then you do 3 months of an IL-6 and it doesn't work. And you go to a TNF as monotherapy, right? And it doesn't work. Now we're at 9 months if you're really, really fast. And how much disease activity has there been? How much comorbidity has there been? We know the VTE is related to inflammation. We know that MACE is related to inflammation. And we know that malignancy is related to inflammation. So the FDA says, don't use this drug because it's not as good as a TNF, although it's probably a lot better than a conventional synthetic, for 9 months, right? And for many rheumatologists, it might be a year, year and a half. It doesn't make sense to me.
Fair enough. So any take-home message for the clinician, Roy, from this paper?
From this paper, yes. So this is a paper which shows that over 5 years, baricitinib does inhibit radiographic progression, both 2 and 4 milligrams.
Super. We thank you for your time. Greatly appreciated. If you want to know more about this paper and others uploaded to the CSF website this month, you get detailed slide kits are available in the publication section at cytokinesignaling.com. Subscribe to the podcast, give us some 5-star ratings, check it out on iTunes, Podcast Media, and give us some feedback. Let us know what you think. Thank you so much for your time, Roy. Greatly appreciated.
Thank you, Peter. You're welcome.